It is a great pleasure to introduce Dr. Carrie Cochran-McLean, who is a member of our Executive Advisory Board and a close friend. She serves as the Chief Policy Officer at the National Rural Health Association. Carrie joined the NRHA staff in 2020. That was a pretty calm year, wasn't it? Where she is the head lobbyist for the association and is responsible for driving the policy agenda for rural health for the 21,000 member organizations. She has more than 20 years of experience working in federal health policy development, including serving in the Senior Executive Services at the U.S. Department of Health and Human Services, Deputy Director at the Federal Office of Rural Health Policy, and as a Principal at Health Management Associates. Carrie earned a bachelor's in sociology from Wilmette University, an MPA with a concentration in health policy and management from the Maxwell School at Syracuse University, and completed a doctorate of public health at the UNC Gilling School with a focus on access to obstetric care in rural areas. Carrie will present, and then we'll have a short Q&A before our panel starts. So please welcome Carrie to Purdue.
I am just going to do a quick shift so that I can see my notes. I am delighted to be here today, and while I'm getting this set up, I will just would love to, hold on, a funny story. Just a second. Do you know how to do this as a split screen? Thank you. All right. So I'm originally from Montana. I've been in DC way too long. And I was talking to my parents, who are both still back in Montana, about coming out here. And they were like, did you know that you were almost born and raised in West Lafayette? And I was like, what? No, I've never heard this in my 40-some years of life. And apparently, before I was born, my parents, who are both faculty retired faculty at the University of Montana, interviewed out here, and it was the big debate whether I was going to be a Boilermaker or I was going to be a Grizzly. And turns out I'm a Grizzly, but now I feel like a special fondness in my heart for all of you, and a connection to the great work and the great learning that you do here at Purdue, and it is really my honor to be here today. I will say, you all are giving me a little bit of a complex being in the back of the room, so if you want to move up, I do not smell. I did take a shower this morning, but I really want this to be an interactive dialogue. I talk fast. There's a lot in this presentation, and the world of federal policy, federal health policy it can get super wonky. So I want you to stop me if you have questions or any kind of thoughts along the way, and then I really am looking forward to a robust panel discussion as we hit the next phase of this. So with all that, I don't know, how many of you have ever heard of the National Rural Health Association? We're going to do some interactive. Oh my gosh, this is awesome. Probably because of Cody, who is fabulous and on our board and leads our public health constituency group. So just for those of you who don't know us, National Rural Health Association, we are a nonprofit, nonpartisan, membership-driven organization, and we really work to be a voice for rural healthcare at the national level. We also work closely with our state partners at the state rural health associations, which, as I have a map here, those state rural health associations work to provide advocacy, education, leadership development, technical assistance to at the state level. And you all have a fantastic Indiana Rural Health Association with Cara Veal and her team. So we are very happy to be close partners with them. At NRHA, we really work to do advocacy, education, outreach, and then we do run the Journal of Rural Health. So there is a research publishing arm to what we do also. And in my job, I am the Chief Policy Officer. My bio, my CEO told me I had to put in there that I'm the Chief Lobbyist, but that always makes me feel like a little gross. It's a good kind of lobbying, though, where my goal really is to raise the issues that people are facing in rural areas and work with policymakers on solutions. And that really, at the core of it, is what advocacy is in my mind. And all of you have the ability to do that too, and I hope do that, both at your local, state, and federal level. So when I'm thinking about advocacy, we have kind of three primary pillars at NRHA that we organize our work, because we really do look at the entire umbrella of rural healthcare. So there's a lot that's involved in that. We think a lot about how do we make sure that we've got a safety net healthcare system in rural communities, that the hospitals can keep their doors open and provide the services that they need, that folks can access specialty care, that there's primary care through our clinic and outpatient settings. What needs to happen to make sure that those services are available? We think a lot about workforce, a constant perennial issue in rural areas, making sure that we've got the healthcare workforce to take care of the folks who live there. Everything from someone to do billing and coding and man the front desk, all the way up to how do you get that specialty care that you need when you need it. And then I think I say pillars, but really this should be kind of at the foundation of it all in my mind, is that we are really trying to build rural opportunity and address the unfortunately growing issues we're seeing in terms of disparities in life expectancy and health outcomes in rural populations. Rural populations on average have a 2-year shorter life expectancy now than urban. And I have a slide, I think, that's going to talk a little bit about that. So how do we get at the fundamental issues that are driving that? Which is, no small feat, but that's why we need all of you to help us in that work. So just a little bit on the rural health landscape for those of you who may be newer to what rural America looks like. I think Randy said it really well in terms of talking about the populations the center works with really being the backbone of so much of this country. Rural America is about 80% of the land mass, and we've got about 20% of the population in this country, depending on what definition of rural you use. And that could be a whole nother hour-long presentation if anybody wants to get weedy on definitions of rural. But rural areas really are the source for so much in this country: food, drinking water, energy production. Again, I'm from Montana, so I like to say recreation and fun. But without that backbone of America being healthy, it is really hard to have a prosperous country. And I think that's overlooked a lot in the debate that happens at the national level. And we know historically, for a lot of reasons, there have been policies that have disadvantaged kind of healthcare and public health in our rural communities. And so we have a lot of work to do to address some of these things. The other thing that we spend a lot of time recently trying to make sure that folks understand is, I think there's a real stereotype with who lives in rural areas and what rural America looks like. And the diversity in rural America is growing, and growing pretty significantly. So there are about 11 million rural residents that are members of a racial or ethnic minority. That's about a quarter of the rural population. And you can see here kind of how that is broken down. And like I said, that's really rising. It was 4% of the population in 2010, and we're up to 24% in 2020. So that's a pretty significant jump and growth. And it's really an important one when we're thinking about the healthcare context. For example, the rising number of minority children residing in rural America is really significant. There's about a third of rural kids that are coming from a racial or ethnic minority population. So how do we make sure that we have a healthcare setting that is prepared and trained to take care of the diversity that we have in our rural communities? And the other thing to mention about rural is it's not homogenous in the sense that it is geographically, depending on where you are in the country, it looks really different. And I don't have to tell all of you that. That makes sense. But, the southwestern part of the country versus the southeastern part of the country versus Alaska, you're going to have different populations and different cultural needs and different issues. And it's important, as we're working on policy, to be thinking about that. So I mentioned the mortality issue. There's lots of different ways to look at this data. I think this one is very striking in that it shows that, there's a really terrible adage that I feel like I say way too often, that rural populations tend to be older, sicker, and poorer, which really I think is a very kind of it's a very negative way to approach kind of policy making. I think there's a lot of assets in rural areas also, but it's a truth that we can't really avoid. And so we see this playing out in our healthcare and our rural populations in a way, especially since COVID, but even pre-COVID, where we've seen a real shift in health outcomes and mortality in between rural and urban populations. So this chart shows that, up until, while overall life expectancy was growing, this shows mortality declining, but we had some pretty good trends, and we're pretty closely tied to urban for quite a while. And then you can see in the 90s, and then this actually, if this only goes to 2016, but if we had the next 10 years of data, it would continue to grow. We're really seeing a widening gap there. And so it's important on so many levels, including when we're thinking about policy development, that we can't have the same approach to program and policy setting for rural and urban communities, because we know it's not working as is. We know that there are some unique challenges happening that we need to be very specific in addressing. And when we think about public health, there is a fantastic last year, for those of you who are at the symposium, Dr. Diane Hall, who is the director for the CDC Office of Rural Health, came and spoke. We were thrilled. NRHA was very instrumental in getting that office created in 2023. That's a newly stood up office. And that CDC Office of Rural Health has done some fantastic work. This is from an MMWR that they put out last year that looked at really among the preventable early deaths and the 5 leading causes of those preventable early deaths. Rural areas are more likely to have higher rates. I'm not saying that very well, but so we have higher rates of heart disease, cancer, unintentional injury, which includes overdose, chronic respiratory disease, COPD, and stroke. And so while depending on the data, you can look, there sometimes is not that much difference in prevalence, but where we see the problem is in the outcome and the mortality and the morbidity related to it. So again, there's a disconnect in terms of how we're able to care for people once they get sick. Okay, so that's all the rural health 101 background I'm gonna do. Not nearly sufficient to give you a total foundation, but it'll be a starting point for I think what Cody and Randy and others wanted me to talk about today, which is the total dysfunction that is Washington, D.C. So with that, I'm going to talk a little bit about the One Big Beautiful Bill Act. For many reasons, that is a hard thing to say. Both is that it's a mouthful, and I have feelings about the bill. So I'm going to call it OB3. So when you hear me say OB3, I am talking about the One Big Beautiful Bill. But there obviously has been some pretty significant change happening in health policy and in healthcare coming out of DC, and then there's some opportunity too. I like to be optimistic about what might be coming out of the Rural Health Transformation Fund. So we're going to spend a minute on that today as well. So OB3, raise your hand if you kind of followed and have a general sense of what happened in that bill as it relates to healthcare. Okay, so this can get wonky way fast, especially when you're talking about some of the changes with Medicaid and other things. So I'm going to keep it pretty high level, and then if you guys have specific questions, happy to drill down and get a little more weedy. So taking a step back, pre-healthcare elements, I think it's really important for people to understand this was a really big bill. And again, we heard a lot about the Medicaid debate, as we should have, because of the significance of the changes, but there was a lot in it. I think it's also really important for people to understand that not only did we make significant cuts to some of the country's key safety net programs like Medicaid and SNAP, This bill is now expected to add $4.1 trillion to the deficit. The Congressional Budget Office, which is, I like to think of them as like kind of the researchers slash actuaries for Congress. They estimate how much every piece of legislation will cost, if it's going to be a saver or a coster to the federal government. That CBO score keeps growing, actually, as they think about the potential implications associated with the bill. So this 4.1 number is actually a newer number because of inflation and other things that they are taking into account. So it's costing the country overall. And on top of that, we are looking at over 10 million people becoming uninsured as a result, or expected to become uninsured as a result of the bill. And again, CBO is a neutral, nonpartisan. They work for both the Republicans and the Dems. So this is pretty much as objective as you can get data in terms of the impacts. As a lobbyist, I feel like I always have to give that disclaimer. So what is that going to mean to rural areas in particular? So the Kaiser Family Foundation, and I'm sure many of you are familiar with their work, they did some research looking at just what the Medicaid cuts alone will look like for rural areas. And the federal investment, again, the federal investment alone is expected to decrease by $155 billion in rural areas over the next 10 years. That's not including the state match that's related to Medicaid. So I would argue that this number is even higher. Indiana is expected to see a decrease of $4.5 billion to their rural infrastructure over this 10-year period. And we're going to talk about the Rural Health Transformation Fund. As this conversation was happening in Congress, there was a lot of concern about the rural health care infrastructure and rural hospitals. Yay to all the advocates who raised that issue with me. Thank you very much. And as a result, Congress created this Rural Health Transformation Fund to help rural areas. The challenge is that even with the $50 billion, which sounds like a lot of money, and it is, even with that $50 billion going into rural communities, we're looking at only a third of the loss over that 10-year period offset. And the Transformation Fund is only a 5-year fund, where these cuts to Medicaid are indefinite, they are permanent. So just having that context in mind is important. You can see here the number of states that are the biggest losers in terms of the Medicaid losses, just for context. But I think the other thing really to look at here is when you're talking about coverage impact, and this is not rural specific data, this is all coverage loss. This growth in loss of coverage is going to occur over time. So I think a lot of people heard the debate in Congress around we're going to lose Medicaid. July 4th happened, the bill was passed, and everyone is kind of like, waiting for the shoe to drop and waiting for the cuts to happen immediately. And the truth of it is a lot of this is going to happen over the next several years, and we won't see the full impact of a lot of this, definitely until like the 10-year scope, but even really like 2028, 2029 is really where we see those numbers start to creep up to that 10 million estimate. You can also see, I think, for those of you who are a little bit more wonky into health policy, the second bar chart is what the CBO estimates in terms of kind of the increase in uninsured as a result of the bill. So the bulk of it, by far, is going to be within the Medicaid scope. So 75% of it being in the Medicaid policy coverage loss. There are some losses in Medicare, and I will talk about that. That is almost all related to folks who are here lawfully present. So that's something that's of interest to this population or this group. And then the other kind of 25% or so is around changes to the health insurance marketplaces. So how many folks in the room are familiar with the health insurance marketplaces? They go by ACA marketplaces, they go by exchanges. So the exchanges, marketplaces, every state calls them something different, which just like Medicaid makes this whole conversation so much more confusing. The marketplaces were created as a part of the Affordable Care Act. And basically what it does is it creates a shopping platform for individuals who don't have health insurance through an employer or through Medicare or Medicaid to be able to go on and buy health insurance at a more kind of affordable rate. And this is a lot of people who may be uninsured. This is a lot of people who may be employed by a small business because there's an exemption for small businesses to be required to provide insurance to their employees. The marketplaces also had a piece of it that provided subsidies through tax credits and other mechanisms to make the cost sharing, so your premium, your monthly payment, and then your co-payments when you go into the doctor's office, there were subsidies or are subsidies that help make that more affordable for folks. So instead of a monthly premium of $1,000 to pay for your health insurance, you might get a tax credit that goes directly to the insurance company, and you may only pay $200. And those policies are part of that marketplace. I will talk a little bit about what changed related to that, but that marketplace has become a really important place, especially for people in rural areas to get coverage, because we have so many folks who are self-employed or who are employed by small businesses and otherwise may not have had access to insurance coverage. So again, there's kind of this disproportionate impact on rural related to that. So the major, when we're talking about Medicaid, going back to Medicaid, and CHIP, for those of you who aren't familiar, is a children's health insurance program. It's a subset of Medicaid, a program kind of parallel to Medicaid that provides coverage for kids specifically. There were 21 different changes to the Medicaid program in the bill. I will not go through all of them, but the bulk of the cuts related to Medicaid kind of fall into 4 big areas. One is around restricting provider taxes. One is around coverage and access specific to expansion populations in states. So Medicaid related to after the Affordable Care Act, there was the option for states to expand Medicaid. That expansion population is the one that really had changes to coverage and access related to the bill. Restrictions for immigrant coverage, and then limiting something called state-directed payments. Again, this can get really wonky, but that I think is an important way to think about it. The way I think about it is that there's an element that's specific to kind of eligible, like the individual and who's eligible and what kind of services they may get. And then there's an arm of it that includes the provider taxes and state-directed payments that's really related to how states are able to run their Medicaid program, which has trickle-down effects then to both providers and individuals. Does that make sense? I think that's kind of the way I've organized it in my brain. So a little bit, I'm not going to spend a ton of time on this. Medicaid is an extremely complex program. It's funny, I have known Medicaid directors who feel like they're not necessarily even experts on Medicaid because there are so many nuances state to state, and there are so many exceptions to the program. But the key thing here is within provider taxes. So an easy way to describe provider taxes, or a kind of easy way, is that states were using this mechanism to basically provide a revenue source for the state version or the state match associated with Medicaid. Because Medicaid is made up or financed from the federal government and from the states. And each state has what they call an FMAP, and that tells you how much the state pays versus how much the federal government pays. The state has to come up with their portion of the FMAP, and provider taxes was one way that they were doing that. Now, it is a provider tax. It also was assessed to payers and like health insurance companies and others. And what it did is basically would provide a tax to those facilities as part of like the state tax structure. The thing that was criticized about that is you know what, we're not going to get into the details of it, but basically this froze how states are able to use that mechanism for revenue. And it's been a really important revenue stream within the healthcare sector. And I'll leave it at that, and I can answer specific questions if folks want. State-directed payments are the other piece of how the state can run their Medicaid program that was impacted. State-directed payments are basically supplemental payments or extra payments that can go to healthcare providers and facilities, so hospitals, nursing homes, and other folks who are providing services under Medicaid through managed care. And states use these a lot. And really, the growth of this has increased a lot in the last several years. And states will use state-directed payments specifically to try to move the needle on certain initiatives or with certain providers that they want to see more activity from related to Medicaid. So in the rural space, we've seen state-directed payments used to help rural hospitals with additional payment or sustaining. We've seen it directed towards obstetric services to try to do initiatives to help with care and management and payment related to OB care. So it's really a tool for states to be able to fund their Medicaid program that will be basically capped and in some cases reduced in certain states. It's pretty high level, but that kind of gives you a sense of it. Within the umbrella part of it, that is the individual and the individual eligibility and outcomes, the big thing we heard a lot about were the mandatory work requirements. So this is for all able-bodied adults, meaning that you don't meet one of the other kind of disability or other criteria under traditional Medicaid. And there are some certain exemptions for populations that wouldn't have to meet this requirement, but otherwise you have to meet the requirement showing that you're either working, a student, a volunteer, or otherwise looking for work at least 20 hours a week. So what we know about work requirements is that most people who are on Medicaid are already working, or there is a reason that they're not working. And so the concern associated with this is that when we've seen work requirements be put in effect in other states under a demonstration, people lose coverage purely based on kind of paperwork processes. And so there is a concern that a lot of folks who are eligible will lose their coverage due to kind of administrative and paperwork process related to this requirement. There are also some changes around eligibility, how frequently you have to prove that you're eligible for Medicaid, how far back you can go to get coverage once you are deemed eligible for Medicaid. Right now, that's 3 months. Moving forward, again, depending on what state you're in, that time period is shortening. There's some cost sharing for services, which is a brand new thing to Medicaid and something we tend to really avoid in the program, knowing that most people who are on Medicaid are extremely low income. And we don't want to have cost sharing and income be a reason that folks are avoiding care. And a couple other, and home and community-based services actually saw kind of an expansion for certain flexibilities in states. I know, this is super wonky, bear with me, it's hard. So that's the main Medicaid stuff. The marketplace, as I mentioned, the big thing here is that that it requires right now, for those of you who, how many folks in the room have applied or are directly the ones who enroll in your health insurance? I'm one of those people. Okay, so for those of you who aren't, you may be on your parents' plan, which is awesome. That was another Affordable Care Act thing. Every year, you basically have an open enrollment period every year for health insurance. For most of us who have employer-based insurance, we may look at the plan we have and decide that we want to stay on it. A lot of us don't think about it and it just kind of rolls over. Now for folks who are on the marketplace, so who are buying that insurance through the marketplaces, they now have to go through the re-enrollment process every single year. And this was put put in place, again, as a kind of a paperwork deterrent in terms of people, if you forget to enroll or if you have some reason that you missed your 6-week open enrollment period, you have to wait a whole nother year before you can enroll in coverage. So it's another kind of barrier that was put in place. And I think that's my perspective. On the other side of from folks who were proponents of this, they would say that will get rid of people who are no longer eligible or folks who may be in there fraudulently. But for those who have to go through that process, that's actually a pretty onerous process. Like if you had to go through and re-register your car insurance brand new every year, if you had to go through, and I mean, if you think about those kind of things, that's like what it's requiring you to do. Okay, and then the piece, oops, I think I skipped it. So there were also a number of things around coverage for immigrant populations. The big thing, and again, I'm happy to answer specific questions on this, but there was an elimination of eligibility for many categories of individuals who were lawfully present immigrants, both under Medicare and under Medicaid. So again, as a reminder, Medicare is the program that takes care of people 65 or older. Medicaid tended to be kind of children's and families and lower income populations or disabled populations. And so there are or were categories of folks who were, again, lawfully present and deemed to be eligible for these programs that were eliminated. And I can get into the details of it. If you look at the third bullet, it also limits who can get coverage and support under that health insurance marketplace, so buy coverage under the marketplace. It limits who's eligible for that to basically the folks in that bullet. That's basically the folks who are now continued eligible under Medicare and Medicaid. So there's a big swath of population that, again, is here lawfully that will lose coverage under those public payers. It also affects hospitals and other providers who are choosing to see those populations, and states that are choosing to continue to cover those populations. It's impacting kind of their federal matching rate for states who choose to do that. And again, I'm happy to answer some specific questions under that. But so it's a big cut in terms of that population that can sometimes be very vulnerable when we're talking about healthcare access. And then last but not least, because I feel like I'm starting to lose myself, much less all of you, there's a piece in here about student loans. Oh yeah, go ahead. Yeah. Yeah. Let's see if I can figure out how to go back. COFA is, I believe, I don't remember what it stands for, but it is populations that are in the territories. A lot of like the southeastern, South Pacific islands are COFA. So it allows them to get access to care in a U.S. setting under the public payer. So I know we work closely with the Hawaii State Rural Health Association, and they're very focused on making sure COFA stays part of it. Yeah, good question. Okay, so for student loans, and again, I'm going to stay high level at this, but there are limits that are being put on a program called Grad Plus that is frequently used by folks who are going into the health professionals as a way to pay for their education. There also are caps put on unsubsidized graduate loans for grad students and professionals like physicians in terms of lifetime caps. So we're hearing from a lot of the schools of medicine and nursing and others that we work with that this is a real deterrent for folks who may not be coming from families or situations where they can pay for med school or had scholarship for med school and other things. So we're concerned about this impacting the pipeline for students. You'll see that this is, most of these are effective in July of 2026, so this is new borrowing, because I know I always raise the blood pressure of people in the room when I mention this, and if there are students in the room. So my understanding is folks who have current arrangements aren't impacted, but moving forward, starting in 2026, there will be some restriction. Okay, that's it. That's as wonky as it's going to get. Thanks for hanging with me. So what does all this mean for rural healthcare? We worked with a very smart group of people, a lot of former Medicaid administrators, to kind of do some analysis about what this might look like in rural. And we know that rural populations are significantly reliant on our publicly funded healthcare being Medicare and Medicaid, and I would also put the marketplaces in there. So we have about 20% of our adult population and a little over 40% of our child population in rural America who are covered by Medicaid. It's a big portion of your patient population if you are a healthcare provider. So as we look at how these cuts will transition to the rural healthcare setting, we anticipate about, and we looked at hospitals because it's a good proxy for kind of other providers in the community, but we anticipate hospitals being slated to lose about 21 cents of every dollar they currently receive in Medicaid funding. So they're going to lose a fifth, maybe close to a quarter, more than that, depending on the state, of their funding under the Medicaid program. And this map helps you kind of understand a little bit about what that might look like. So again, I talked about the impact to rural overall being $155 billion. The map actually shows Medicaid cuts to the entire population, so not just rural. So you get a sense of the darker the blue, the bigger the loss that they will see to their Medicaid program, because this is not going to hit every part of the country equally. And the lighter colors, the less of the impact is due to the fact that those states have not expanded Medicaid. So they have fewer individuals who will be impacted by the policy changes. When you look specifically at rural areas, the second bullet there lists the rural areas that are expected to see the biggest losses. This is the same list that was earlier on in my slides, but some very rural states that are expected to take some pretty big hits. And I know as you're sitting here thinking about kind of 20% doesn't seem like that much money. Why are we concerned? The reason that we're really concerned is that the rural healthcare infrastructure overall is how do I say this nicely? is vulnerable. We have at this point in the last 15 years have had almost 200 rural hospitals close or give up doing inpatient services, which is how we think of a hospital. And this map shows that we've got almost 450 hospitals that are vulnerable to closure. So our rural hospitals, on average across the country, half of them have negative operating margins, meaning that they bring in, they are operating in the red. And if you think about taking a 20% cut when you're already operating in the red, that is going to put your hospital, your healthcare facility in some really difficult positions and having to make some really tough choices. When you look at the map, you also see that the states that are non-expansion states and have not expanded Medicaid have more vulnerable hospitals and more folks that are really like potential to lose access to care in their rural communities. Okay, so that's kind of high level. I'm going to pivot now to talk about the piece of the bill that people added, the Rural Health Transformation Program. This was created, again, to try to help address the potential list of, vulnerable hospitals. We had a lot of members of Congress that were from Maine and Missouri and other southern states who were concerned about the impact of this on their rural hospitals and their rural hospitals keeping their doors open. And so as a solution to that, Congress created the Rural Health Transformation Program. This is a new program. I was doing this historical game with my colleagues. I do think that this is the largest single infusion of money into a rural community we've seen in recent history. So this is a really big deal for really rural America and a great opportunity. It is $50 billion over a 5-year period of time starting next year. There are a lot of weeds associated with how this funding can go out, but basically it's in 2 tranches. One will go equally to any state that applies. So it could go equally to Texas and Rhode Island in terms of the amount that states will receive. And then the other half, the other $25 billion, will go to states based on their application to CMS and CMS's discretion. The application needs to include a detailed plan for how they're going to transform rural healthcare in their community. All of this is wonderful. We are very excited about this opportunity for investment. The timeline is extremely fast in that the awards are going out. They have to be out by the beginning of the decisions have to be out by this calendar year. So if any of you who have ever been involved in a planning process, trying to develop an entire plan to transform a state's rural healthcare in 6 weeks is or 2 months is pretty challenging. But that is kind of the position that we find ourselves in. So it's an opportunity, but it is, I think, not. It's definitely one that's going to need to be have community members very engaged, have providers very engaged and very informed to make sure that we're spending this money wisely. A little bit on the transformation fund, like how the funds are going to be, what that discretionary criteria is going to be in terms of how those funds, that $25 billion is going to be distributed. Things like how rural is the state, what's the condition of the hospitals in the state, other factors that the administration might want to really emphasize in terms of access or their plan. The important part to realize here is in that second half, that $25 billion that the administration has discretion on allocating, only a quarter of states, a minimum of quarter of states have to receive that money. So the administration could decide that only 12, 13 states in the country actually get that second half of that $25 billion. So not every state is going to necessarily benefit from it. And then thinking about, we haven't seen the guidance yet. Yeah, question. Yeah. That's a great question. So I was just about to say, we haven't seen the guidance from CMS yet. So there's still a lot that we are looking to figure out. We have heard, we were lucky to have a meeting with Dr. Oz about a week after the legislation passed. So he talked to us about this. And he very much is looking to the governors as the leaders in this. So my understanding is that the governor can designate another entity within the state government to take the lead on it, but that the reins are really being driven by the governor's office. And I actually have in my notes, I will look it up for when we do the panel. I do know, I did talk to Kara about how it's working in Indiana and can give you a little bit of insight of that during the panel. Yeah. But there's a whole lot, that kind of raises a good point, that there's a whole lot of discretion. So in some states, we've talked to state advocates, rural advocates who are instrumentally part of the planning process and trying to help do data collection and information collection. In other states, it's been kind of handed just off to the Medicaid department and no one's heard anything about how it's going to be used. So there is a lot of leeway in, again, how the administration and how states want to be spending this funding. We have seen CMS did put out a website that talks about the strategic themes associated with the funding. Making America Healthy Again is definitely one of the prominent themes. So issues around states addressing population health and prevention and chronic disease, all of which are very important things to rural. Talking about sustaining access. So what are the ways that we can support access to care, a lot through kind of financing and care delivery, workforce development, and thinking about how we do recruitment, retention, and they're very focused on scope of practice within a state and having states do some work in that space. Care innovation, so how do we move our rural communities towards value-based payment and things like clinically integrated networks? And then supporting technology. This administration is really big on remote patient monitoring and wearables and AI, and how do we bring that into rural areas? The challenge is that this is 5-year funding, and we have talked to states that are telling people absolutely do not propose anything that is going to need funding after these 5 years because there is no room in the state budget to support it. So if you think about that, it is a very kind of unique set of things that you can pay for and sustain in that context. And we met with the deputy CMS administrator recently, and I really liked the way he framed it. He framed it in the sense of, we know that transformation, it takes a lot of investment, especially for historically underserved communities. So look at this 5 years of funding as kind of seed funding or transformation funding to be able to put in the infrastructure and kind of the planning and formation that a state needs to be able to then have their healthcare system kind of go that next step. That is definitely easier said than done, especially when you have like a 6-week window to apply for the program. So there are a lot of challenges and opportunities associated with this. This talks a little bit about application and timeline. So the legislation passed in July. The notice of funding opportunity or NOFO or grant application is supposedly coming out any day now. I actually didn't send my slides to Cody until I think yesterday because I was like, I'm going to wait and get the NOFO details and put them into the presentation, and it's still not out. But supposedly it's coming out any day now, and we're getting that directly from CMS. So we'll get that out. The states will have until early November to write their applications. And then CMS has pledged to do a review of those again in another 6-week period of time, and decisions being in December. And then the actual funding starts in January of next year. The other thing that is important, and I know if you guys have never really been involved with federal funding, none of this means anything to you, but there is a clawback of any funding that is unspent by 2032. So there really is not a lot of extra time for folks to catch up in their planning and implementation effort associated with this. For those of you who are into this, I have a lot of different resources on here where you can learn more, as much as we know right now without that CMS guidance out. Okay, I'm going to talk a little bit about what's happening in Congress, and then I promise I'll stop talking and we'll take a break and we'll do the panel. So aside from the One Big Beautiful Bill, which is really dominated all of the conversation in Washington for the first half of the year, very little else got done. So now we find ourselves in this situation where the federal budget, for those of you who don't follow it closely, actually operates, the federal budget year is October 1st through September 30th. So October 1st will be the start of the fiscal year 2026 federal budget. And that federal budget determines all of what we call discretionary funding. So kind of like non-defense, non-mandatory funding for the country. No conversation happened really about the federal budget during the OB3 process. And so now the Senate and House are kind of scrambling to pull together their proposals for what the budget will look like in the coming year. This is important because one, if they don't figure out what that budget is going to look like, they need to develop what we call like a short-term continuing resolution, or like a little stopgap, or the federal government shuts down. This is a conversation that it feels like we revisit way too often in Washington. Right now, rumor on the street is they're going to be able to figure it out, but you do hear rumors of potential shutdown, especially when you've got a Congress as closely divided as ours is. There's really not that many House Republicans that that Speaker Johnson can lose from majority support without kind of throwing a wrench in the whole process. So if the Freedom Caucus or some other group decides that they don't want to move forward with the budget, they have problems with it being put in the budget, they can cause a government shutdown. The reason that I put, and this again is way too many weeds for the vast majority of you, but the reason I put these numbers in is the president's budget came out last spring. The way the budget process works every year is that the president starts early in the year and says, "Hey, Congress, this as the leader of the United States, these are my priorities to be in the federal budget." That's called the president's budget. And then Congress takes that and they say, we want to do this, we don't want to do this. Obviously, the party aligned with the presidency tends to support the president's priorities. And then the process starts from there. The president's budget this year zeroed out a significant number of health-related programs, including some core ones to the federal or to the rural space, the state offices of rural health, the Medicare flexibility program that supports small rural hospitals. So we were very, very nervous and did a lot of advocacy with Congress to try to get Congress not to support the president's lead on that. And luckily for us, and I think probably as a result of the cuts that we're going to see due to OB3, the Senate and House put in some very generous numbers related to rural health and rural hospitals in their proposals. So at this point, House and Senate both have their proposals out. They're different, so they have to figure out the compromise, which means that, like I said, we probably will be on what's called a continuing resolution for a period of time until they figure that out. This is the weedy numbers associated with both the Senate version and the House version. Again, the key for you to know is that we ended up seeing bumps in a lot of our rural programs, so we absolutely want Congress to move forward with developing a new budget for FY26 using these numbers. The other thing that Congress needs to do, are the current year funding levels so that you have a sense of where there were bumps up. Yeah, I know, it's a lot of information, but I'm one of those people that likes, I want all the numbers, I want the data. So I know anybody who teaches like a public speaking or PowerPoint presentation would look at this slide and die because it's not at all what you're supposed to do, but just ignore that. And then the other thing is, so the annual budget is like the bare minimum Congress should do every year, like the bare minimum. I mean, this is it is the one thing they have to do. And they don't always do it. But there are a number of other things that are important to rural healthcare that, because I mentioned the Congressional Budget Office, or CBO, in order to get any kind of policy change done in Washington, you have to have a pay for, right? You gotta have some way you're gonna afford that policy change. And because a lot of what we wanna do in terms of policy payment costs a lot of money, what Congress ends up doing is short-term extensions of whatever that issue or payment is. So we've got a bunch of those kind of what we now call extenders under health policy, under Medicare, that we need addressed before the end of this month, or they will expire. So that is certain hospital designations. That's the flexibilities that we saw under COVID to do telehealth under Medicare. That's some special payments for rural in terms of EMS and ground ambulance. And then it's funding for things like community health centers and the National Health Service Corps that helps to place people in underserved areas. So this is also something that, along with the federal budget, is something that we're very much pushing Congress to take action on before the end of this month. Last is the marketplace. I mentioned the marketplace. I mentioned the importance of it to rural areas in terms of getting coverage. Separate from OB3, Back in COVID, there were some enhancements added to the subsidies or the payment support for coverage in the marketplace to help people stay covered while everyone was struggling with COVID and making sure people had access to care. Those subsidies are looking to expire at the end of this calendar year. The challenge with that is that those subsidies have helped a lot of people keep coverage. We're guessing about 3 million people keep coverage, a lot of those being in rural areas. And without them, we're going to be seeing people pay a lot more for their health insurance under the marketplaces. So Congress is also struggling with whether they are going to extend these, what are called enhanced premium tax credits, to help people maintain coverage in the coming year. So that's another big issue that we're pushing on. In each of these slides, you will get linked to ways that you can engage and advocate with us on these issues. So with that, I am at time, so I am just going to fly through some of these other slides, but they are resources, and I'm happy to talk about them during the panel discussion. So I, like I said, do the advocacy education part of our portfolio. We also have a program services part of NRHA's portfolio, and they do some amazing work that I wanted to make sure you all knew about. One of those things is that we have a really significant community health worker training program and network that we have worked with partnership and with others on starting in 2012, sorry. And we started on the US-Mexico border, but we have done initiatives related to community health workers in Appalachia, related to oral health. We're doing one right now related to aging in place in older adults. We did trainings around COVID-19. So this is a space, if you're interested in CHW work and CHW training, that we have some great resources, and I'd be happy to talk with you or connect you. I also mentioned the growing diversity in rural areas. We have a campaign that my colleague and I created a couple years ago called the Faces of Rural campaign that's really meant just to educate and build awareness on the diversity that's in rural America and to celebrate that. We have, as I mentioned, the way we're organized, because we are such a large association, we are organized in constituency groups so that everybody who is part of NRHA feels like they have a home. We have 8 different constituency groups, including a student constituency group. I put on here, it's $20 to join. If you are a student, you can engage with us even if you aren't a member. Don't tell my boss I said that. We will give you all of our resources anyway, but student membership brings opportunities to do leadership. We have scholarships to some of our conferences. So if you're interested in getting more engaged in rural health and in advocacy, definitely check out the student membership. Talk to Cody. He's a great advocate for us on that space. We also have a fellows program that is intended a little bit more for people who are early to mid-career to develop leadership and really advocacy skills. And they have in-person events, trainings. You meet with people in Washington. You work closely with my team on developing some policy statements for the association. And the applications for that program, I believe, close this week or today, sometime soon. But if you're interested, let me know and we'll see what we can do. And then aside from all of that, you don't have to be a member. We would love to have you help us raise the issues that rural communities face. We have lots of ways to do that. I didn't put them all in my presentation. One of those ways is an advocacy campaign where we will give you all of the information, including a pre-populated message. If you want to use it, you don't have to use it, to write directly to your member of Congress, and you can do that through our platform. So you don't need to even look it up and send a separate email, though if you want to, you're more than welcome to. So lots of resources there. We also have weekly and monthly education information opportunities. So please check this all out. And with that, Cody, it is 9:59, and I think time for a break. And then we'll come back for the panel. Does that work?
Yep.
Okay.
So thank you all. We'll take a break. Thank you, Carrie.
Yeah.